Bien, bonjour tout le monde, buenos días. Vamos a empezar esta primera sesión.
Hello everybody, good morning. We're going to start this first plenary session of the day dedicated to dual pathologies. Now we have a panel of experts, very renowned experts with a great professional experience. They're going to talk to us about very interesting topics. So without further ado, I'm going to give the floor to Dr. Nestor SZERMAN. Dr. Nestor SZERMAN needs no presentation, needs no introduction. He's a professional, he's been involved, he's participated many times in the different editions of Biarritz, but if you do not know him, he works at Hospital Gregorio Marañón in Madrid. He is the president of the Worldwide Association of Dual Pathology, and he's got a very wide experience in the field of addictions. You have the floor, Nestor. All right, so hello, this is a session in Spanish, and thank you, dear friends. Thank you to the organizers, to Arkaitz, to Jean-Pierre. Thank you for inviting me to be at this very beautiful city. I think that the storm is helping us remain here, and it prevents us from going to the beach. So, well, now I'm going to devote the next minutes to tell you about gambling. And gambling, this is the term that we use. We keep the English term gambling dual disorder. This is what I'm going to tell you about. And I'm going to tell you about evidence-based prevention for gambling. These are my disclosures, and this is the agenda of my presentation. I'm going to introduce the concept of gambling dual disorder. I'm going to tell you about evidence, the different evidences in terms of prevention, and then the conclusion. So from an evolutionary point of view, gambling is understood as a universal activity. It's just like drugs. Drugs have been used for thousands of years, alcohol, opioids, cocaine, and the same goes for gambling. It is part of the human condition. I mean, the brain has needed that for social functioning. So most people in the world gamble, but only some vulnerable people do have a problem about it. Only some of them have a problem with gambling. And it can be as serious as any other mental health disease. So gambling behavior should not be classified as addictive because it does not depend on the type or frequency or amount of gambling, but rather on the vulnerability. So we have to observe this from a dimensional perspective. There's normal gambling, but there's also gambling addiction. And between those two extremes, there's a variability of gambling with many problems. So we have heard for many years, and it was the same for drugs during the 80s in the last century. I mean, we've always heard that gambling is a behavioral problem, and we have often ignored that gambling is a mental disorder. So the vice gambling addiction, ludopathie in France, is a word that carries out a lot of stigma. I mean, people are trapped and caught by this, and people stay a long time gambling, and this is going to provoke some changes in the brain, and this is going to entail a gambling disorder. So this is the kind of comments that we hear in order to ignore that this is a mental health disease. It is a disease of the human brain. So the perspective of dual disorders tells us that psychosocial acceptance makes us closer to gambling, but it is some personality traits, personality features that will determine whether we are resilient or not to gambling and to suffering a mental health disease. So in accordance to the scientific community, mental disorders are brain disorders, and they involve cognition, emotion, and behavior. So any dysfunction in the brain will alter our mental functioning and will lead to a disorder. Neuroscience tells us that addiction involves a set of interconnected brain processes, and that it is not possible that these brain problems have a unique symptomatic expression, for instance, the uncontrollable use of gambling. Now, from the point of view of our research in animal studies, we differentiate between seeking drugs or seeking gambling. And seeking drugs and taking drugs and taking gambling and seeking gambling is interconnected, but what really matters here is seeking gambling. There is a word in the field of gambling which is chasing, and chasing would be the equivalent of seeking gambling. Now, many years ago, this article was published in order to support the gambling addiction, the disorder. One of the fundamental aspects of this article is that only a minority of people exposed to drugs or to gambling will develop an addiction. So we have to move from the classical paradigm that tells us that addiction depends on frequent exposure. The new paradigm says that it depends on the individual paradigm. It's not because you play that you will be addicted to gambling. It's because you have a certain traits that will lead to that. So high-risk factors for dual disorders. These factors are organized also genetically, and they're existing there, and they're going to exist even prior to any symptoms of
Recording
gambling.
in progress.
So, well, we have gene factors, genetic factors, we have environmental factors, and both will make people more or less likely to suffer from mental disorders. So it could be drugs or gambling or dual disorders. According to the epidemiological studies, there is a minor percentage of the population, 0.4%, which will suffer gambling disorder. And according to epidemiological studies in the US, we're told that 96.3% of people suffering from gambling will suffer from another psychiatric disorder, regardless of the personality traits. And when we think about psychiatry wards, we know that 5% of the people there have gambling disorder, even though they may have been admitted for other reasons, like psychosis. So that's why we now have coined the term gambling dual disorder. It's not out of narcissism that we have a new term. It's because we have to draw the attention of clinicians. Whenever there's a gambling patient, it's very likely that they have another disorder. So we're moving now to precision psychiatry, and we were told this is nothing new. Hippocrates already told us that it's more important to know what sort of person has a disease and rather than the disease itself. We know that every drug has a different effect in the brain of people. Amphetamines may people with ADHD improve their effects. Now, gambling has an effect of rewarding for vulnerable people, which is very different from the effect for other people who are less vulnerable. And this is what makes them develop a compulsive problem. We know that there are sex differences, and in male population, genetic factors are determining in order to suffer gambling gambling disorder. And for women, it is rather environmental aspects which will lead to that. And from these perspectives, we have three main objectives. We have a transdiagnostic classification that allows us to identify the phenotypes and the biotypes. For example, if there's a great impulsivity or if there's ADHD, and this leads us to a personalized treatment, a precision treatment. And this has to as well encompass prevention. We need prevention based on evidence. In medicine, our understanding comes from evidence. There is prevention of gambling based in evidence, but it is not well established that the strategies to reduce gambling are actually based on scientific evidence. Normally, we talk about prevention that is not based on evidence. I mean, there are lots of campaigns that demonize gambling. It's just like the Salvation Army. It's exactly what the Salvation Army does with alcohol. Or, you know, sometimes there are more offers to prevent gambling. But this is not useful. In terms of types of prevention, there are many different types. I've selected this kind of preventions: primordial, primary, secondary, and tertiary. Primordial prevention is aimed at the general population. Primary prevention is aimed at a population at risk. Secondary prevention is aimed at people under treatment or with problems. And tertiary prevention is aimed in recovery. So who are the risk population? Well, children and adolescents with high impulsivity should be identified, and a population as well that may have been diagnosed with HDAD, or a population that have a high density of mental disorders around them. For example, people with relatives with bipolar disorder or HDAD, or young people with behavioral disorders, with impulsivity, or even young people or just people with psychotic traits. Adolescents are in general more vulnerable because they have a more immature brain, so adolescents must be protected. But we know that universal prevention in programs aimed at adolescents has failed to influence risky behaviors. So patients should be educated about their own personal risks, the risk for them and the risk for their family. Education in the family is a very important factor, because educating parents, because it has a profound effect in the behavior of adolescents. So people should be educated on those risks. Now, the availability of gambling, does it have an impact in gambling problems? I mean, if there are more casinos in Biarritz, are there going to be more problems with gambling? It's just like saying that if there are more bars, there's going to be more alcoholic people. Well, this shouldn't be the case. It is true that availability of gambling could be a factor for people to relapse when they suffer already the disorder. Now, there has been a study, for example, on prevention and harm reduction, for example, reducing supply, reducing demand, reducing risk, reducing the harms. But the strategies that have been reviewed are not consistent, and they don't reveal that we're doing things correctly. Now, in this harm reduction systematic review for people who are gambling online, we do not find any correct results. We need more studies, and we know that 1 out of 10 people who have gambling disorder are going to seek professional help. And we think it is very difficult, however, to recruit patients with gambling disorder. Here at our hospital in Madrid, in Gregorio Marañón, we have a study aimed at the general population to identify people suffering from gambling problems. We know that genetic factors play an important role. There's the polygenic risk score. There's a high genetic risk. This is a factor. This is a quantitative factor. There are people who are very vulnerable, mildly vulnerable, or not vulnerable. And we have to take this into account. And we have developed secondary prevention for controlled gambling, for those who suffer a mild gambling disorder, to limit the amount of time or the amount of money, but this leads to results, but for people who have a very mild disorder. And then there are apps to control gambling, but this only works for people who have milder problems or for those who refuse to enter to treatment. All evidences tells us that we need to have an integrated treatment for dual pathology and not only for gambling disorders. So the diagnosis has to identify other symptoms that accompany gambling disorder. And this has to be a dimensional diagnostic, mild, severe, and the treatment has to be biological, psychological, and social in this order. First of all, biological, and then psychological and social. And treatment has to focus on the different diagnostic categories, but also on impulsivity, which is very relevant for people who have gambling dual disorder. We know that patients are very heterogeneous, as in other mental diseases. And once we have identified the phenotypes, we have to identify the biotypes or the endophenotypes. Impulsivity, again, is very important. There are studies that indicate us that there are some genetic markers and that allow us to follow up the results of the treatment. And regarding the concept of precision psychiatry, it's very important to know that cognitive behavioral therapy, the standard CBT, does not work for patients with gambling dual disorder. Patients get bored and patients may increase the risk of dropping out, of disengaging. And we know that boredom provokes a stress response with elevated cortisol, and this is a very potent trigger, actually. So be careful with providing standard responses to our patients. And the same goes that with pharmacological treatment. We know that if we give the standard pharmacological treatment, naltrexone, for example, and N-acetylcysteine, we know that people do not respond in the same way. I'm going to finish soon. Tertiary prevention tells us that 20 years after the diagnosis, normally gambling disorder evolves into remission. Normally, there is remission for gambling problems even in 1 year, but we know that most people may have problems with relapsing. All the studies tell us that relapsing is very frequent. So being a gambler, a pathological gambler, is a condition, and this is never fully resolved. It's never cured. So we must orient people under treatment towards recovery. We must orient their impulsivity to activities that take into account this impulsivity. And we know that this has not been taken into account. All prevention programs have not taken into account scientific evidence. So it's true that very often we only use common aspects, and we know that this does not work. And this is the future of prevention. It's the paradigm based on neuroscience and precision psychiatry. So we need to treat people first instead of gambling disorder. We need to see their phenotypes, their endophenotypes, and I think that this is fundamental. And new technological tools like AI will allow us to move more rapidly towards a solution. So here from the WADD, we're organizing our next annual Congress, which will take place in Shanghai, in China, in June next year. We hope to see you there. Thank you very much.
Thank you very much, Nestor, for your excellent presentation, and not only for respecting the time, but also for giving us 3 more minutes. I will give the floor now to Dr. Ignacio BASURTE VILLAMOR, with large experience with addictions. He is responsible, he's at the head of the manager of López Ibor Clinic in Madrid. He will tell us about the trouble with tobacco use and dual pathology, dual diagnosis. Hello, everyone. I hope you can hear me well. Good morning, everyone. Thanks to the organizers. We felt very warmly welcomed. Thank you all. Thanks to the organizers and dear fellow colleagues. We're going to talk about tobacco because in the lines we are working more, as you know, Nestor, Carlos, Pablo, we work all together in dual diagnosis. We are part of the foundation and the association of dual diagnosis. There are some niches that we do not address that often in the current practice, such as gambling. Dr. SZERMAN referred of, also another aspect which has been more addressed in other countries, such in the States, in the middle of the second part of the 20th century. Well, in Spain, it was not sufficiently addressed. The handling was not appropriate, and a question was raised. Indeed, tobacco, as it was set in Spain, as it was envisioned in Spain, is an addiction which is absolutely ignored. Dr. SZERMAN raised the point whether tobacco is addictive. But treating tobacco is the dual diagnosis, the dual pathology, which is most ignored. Systemically or structurally, it is never been tackled in a comprehensive way within the treatment plans. I don't know about your experience in France, but I will tell you about the survey, the epidemiologic study that we undertook, but apart from smoke, tobacco shows that we are not seeing nor diagnosing it and nor treating it. So there is a bias as for the handling of this dual diagnosis, which generates an important issue of health. Dr. SZERMAN told about this work of Dr. Folco and her team, and they said that tobacco is a brain problem. We can see tobacco as it is being seen still in Spain. And from a traditional point of view, people who suffer from this trouble, it is because they do not decide to quit smoking. If they don't want to, they don't do it. It's because they don't want or they can't. But from the point of view, from the traditional point of view, even clinicians, we do not face it in an appropriate way. We consider it as a voluntary behavior which doesn't require any treatment because there are other more important subjects. From a clinical point of view, we could say, and we have a sufficient neurobiological base and genetic base to see that indeed consumption use problem does not rely on the person itself, but of individual vulnerability. And that way, within the international classification of international diseases, the C11th, we can find that in effect they are the required criteria, as well as opioids and other stimulants and others such as alcohol and others. But when we review clinical records, we can see that these data of consumption are gathered, but tobacco data are not considered that way. There are diagnostic criteria very similar to other substances with severity, and these characteristics are very similar to the rest of substances. So these are addictive substances which are still classified but which are not diagnosed yet. About the impact of tobacco, yes, we can see to which extent, well, if it were a virus, it would be a perpetual pandemic with more than 8 million deaths per year. 1 in 5 deaths from preventable causes is attributable to tobacco. 80% of smokers live in low or middle income countries. So there is a social important vulnerability, and it kills much more than other substances, much more than alcohol or illegal drugs or accidents or suicides. However, we keep on this, life expectancy gets shorter, and not only this, 50% of all cigarettes smoking in the world is done corresponds to people with mental diseases or mental troubles. So less than 20% of the population smokes, 50% of cigarettes, and most are psychiatric patients. This is associated to these severe mental troubles. We can see that this shortens up to 25 years in terms of life expectancy. And we can see that within these populations with mental disorders, the non-smokers, they have a less life expectancy, but there is a huge difference with the smokers aged more than 25 years old. Well, this is to sensitize a bit, to raise awareness about the problem that within mental health and addictions we are ignoring some factors, and it is a systemic negligence and structural negligence that we have to tackle at the Foundation and the Spanish Association of Dual Pathology. Other specialties well took the situation, the oncologist, cardiologist, and other physicians, and knowing that it is an addiction, we do not tackle this problem, because between 10 and 20% of population with severe mental troubles were not treated or received any treatment. This is a vulneration which, at the end of the day, it is not seeing this as a trouble, and it has all the features of this addictive disorder. The study we undertook in Spain, just to tell you about the results and how we should handle it and integrate it within the problem that we face now about the stacking of dual pathology. The study design, it was done in Spain in 8 centers at national level, with 180 patients in several units, day hospital or in hospital. What we could see amongst the most frequent diagnoses, psychotic troubles, personality and use of substance troubles. We could see that at the end, 76% of people were consuming actively tobacco. They were active tobacco users. 71% met DSM-5TR criteria for OCD. We discarded 5% who indeed consumed tobacco without meeting the criteria. This highlights the importance or relevance, taking into account that in general population we have 20-25% of population who are smokers. So that means 3 times more the population with mental troubles who consume. When we talked about severity, well, more than 50%, well, had these troubles due to tobacco use as well as moderate or severe trouble. So not only we can see that these people are vulnerable as for the major prevalence, but in addition, they present more severity. So this is linked to the use of cigarettes and the frequency and dependence. When we saw in therapeutical areas, we could see that gravity and prevalence was much higher in hospital people regarding or compared to ambulatory or daily hospital, daily care centers. And as for the consumption of substances, well, this means that finally, when we address or when we visit someone with consume problems, we can realize that the functional circuits of reinforcement, well, they will be the same as for the rest of substances. And this makes that we have much more polyconsumption with tobacco. This is a bi-directional aspect. We never tackle in a comprehensive way the consumption because we still ignore tobacco use. And this is a reality when it comes to see how many of these people had received a pharmacological treatment to quit smoking. And we could see that more than 70% had never undertaken any treatment, and the treatments that were implemented were with agonists, with substitutes of nicotine or bupropion, and the cytizine or bupropion. And this would be the psychotherapeutical treatment, virtually non-existent. Then this is a reality. I don't know whether in your medical centers you tackle this problem of tobacco apart from the rest of substances, but what we perceived is that psychological intervention or support was practically zero or very little, and this will lead to more relapses or dropouts of any treatment. So it is crystal clear that there are clinical aspects that we measure, such as impulsivity and functional impairment, and we could see that tobacco not only people smoke, but people are deregulated and deteriorated. So it will cause this functional deterioration. We could see that there was a very characteristic profile factors associated with TUT, and well, it was a risk factor very important for continuing with the use of tobacco. This is the picture that summarizes all we did about the high prevalence of tobacco use disorder. This man impulsive with an associated consumption, this infra-treatment, and this trouble caused by the use of tobacco. When we look at the neurobiological question, we see that some chromosomes and polymorphisms, which are very important, and we can see that there is a vulnerability between 40 and 70% according to studies. We also have to take into account that not only the neurobiological question, but the genetic, because when handling it or combining it, this cytochrome, well, with all this stuff, well, if we have a look at dual pathology, prevalences are very high in schizophrenia, major trouble, PDH, which identifies this profile of a man impulsive and with more risk or vulnerability in consumption of substances associated to the target that we might aim at. They smoke because they are ill, or is it the contrary? Well, we can see that there is a shared dysfunction and a relief, an initial relief, but tests are determining at the end of the day reduction of smoking helps at midterm with some mechanism, functional mechanism, as well as adherence and continuity to the pharmacological treatment. So it is very important that both mechanisms exist and we have to take them into account for the development. We are not going to talk about personality troubles, but this will be a determining factor in the development of addiction. This is, we can see the high prevalences regarding the general population between 10 and 20, and between the 18 and 25%. We have to dismantle this myth that they don't want to quit, they are not prepared, that it worsens mental health, but we have sufficient evidence so that we can say that these people with severe mental disorders will have a high prevalence. There are several pharmacological treatments that allow us to do an efficient handling. We have substitutive treatments and other drugs, which will be safe. This test with people who have used these treatments, we can see that they are safe, they are efficient in psychiatric patients. We can see this RTMS that allow us to do a comprehensive handling in this dual diagnosis, which is a bit our aim. Aside, we have to take into account that quitting smoking doesn't always mean leaving or letting nicotine aside, because within the handling of these addictive problems, this has been a norm that we defended the use of e-cigarettes, snusky, and nicotine. Well, there are evidences in some countries where this has been tested, and we finally see how diminution has been important, and this decrease, and we will have to see short term and in middle term, long term, whether somatic troubles can diminish with their impact. But we talk of decrease of harms versus total abstinence. We do not need to be that dichotomic, and maybe with this severe troubles, mental health, well, we can talk of reduction of replacing tobacco by agonist or nicotinic drugs. We talk of clinical stabilization and abstinence as the last process. The treatment has to be personalized, customized, and this metabolic rate that is done through a predetermination, and according to the dual diagnosis, we need to orient it. The rapid metabolizers of cytochrome, this would help us a lot to have these other treatments more than with a substitutive treatment. There is a combined therapy in which we can use. We are validating a bit, so we can see this efficiency in people with severe mental disorders who have more difficulties to abandon or decrease the use of tobacco. And this combination seem to be the trends marked by evidence. So this would be the therapeutical algorithm, or this screening and diagnosis, taking into account all this, apart from this diminution or quitting, and 5 realities that we have to assume. It is a mental disorder. Many people, and in the clinic environment in Spain, they do not consider it as such. Psychiatry has, forgotten this sometimes, but taking into account that it is a mental health disorder, we do not address it properly. And we know that we have sufficient evidence of treatments which are useful. Not treating doesn't allow to better help our patients with this, in particular these people with dual diagnosis, and a problem which is the dual diagnosis, and which is the most frequent problem within our context. Well, that was all. Thank you very much. Thank you, Dr. Basurte, for addressing this pathology, which has been, has been banalized. I will give the floor to Arkaitz Richie. I have the pleasure to co-chair this session.
So we have been talking about gambling, we've been talking about smoking, and, well, with AIDS and hepatitis, we're going to move to a topic that was at the very core, at the very origin of this event, which is ATHS. So we're going to talk about opioids, and we're going to welcome Pablo Vega, who is the Vice President of the Dual Pathology Spanish Society, and is also the Director of CAD-1 in Madrid. So he's going to tell us about the endogenous opioid system, relevance and treatment. Pablo, the floor is yours. Thank you very much. Well, first of all, I would like to thank you all for being here. Thank you to the organizing committee for inviting me. As a doctor who works in a center for addictions, well, of course, I've been working there for 30 years, and 30 years ago we were working on opioid use disorders, OUD. And today I'm going to tell you about all these issues, but from the dual pathology perspective. So this is my disclosure. And this is what we're going to talk about, the agenda. First of all, we're going to talk about the epidemiologic of OUD in dual pathology. But we need to bear in mind the current situation of opiate use in Europe. This is a report. It's the European Drug Report that tells us that 0.3% of the adult population in Europe used opiates in 2022. And, it means that in Europe there are over 860,000 people who use opioids, and there are 63,000 cases of people being admitted in treatment for drugs in Europe. And the fact is that since the moment of the first use of heroin to the moment of treatment seeking, 14 years go by, and we need to know that 74% of the deaths for overdose are for opioid use with other substances. So we have other studies, more recent ones. This study, multicentric study with over 15,000 patients in the Czech Republic, in Norway. It talks about prevalence of dual pathology, a very high prevalence, 57%, and the most important disorders or the most frequent ones are anxiety, personality disorder, and depression. There are some gender differences regarding dual pathology in both countries that were the object of the study. And I would like to tell something about this sex difference. It's the effect of telescoping in opioid addiction. This says that women develop addiction phenotypes, and as a consequence of that, they have problems in less time than what happens for men. And this is a study that was made with mice, and after the continuous administration of fentanyl, the craving symptoms appear earlier for women than for men, and for the male population, complications showed up, but later on. So this establishes this biological base of the difference between men and women. This is a systematic revision and meta-analysis with over 100,000 patients, and this establishes that, 64%, and this is a percentage that is repeated, 64% of prevalence of disorders. The most prevalent one is ADHD and depression disorder. So we see that for personality disorders, we see a very high prevalence of social disorders and other disorders for patients who are opioid users. This study tells us that half the opioid prescriptions in the US go to patients with mental diseases. So on top of this, people with mental disorders, 20% of them, they take opiates. And it is twice as much than for the general population. So now let's talk about the endogenous opioid system. There are three families of endogenous opioid peptides. There's endorphin, encephalin, and dynorphin. And here we have three families of receptors: mu receptors, kappa receptor, and delta receptors. And these families of peptides may bind with those specific receptors. So if there's an intervention in the system, there could be deficits or excesses in the perception, in the behavior, in the mood, and this is translated into specific expressions that are very similar to those in other psychiatric fields. Here, for the mu receptor, there's analgesia that compensates, and if there is a dysfunction, either by default or by excess, this is related to other pathologies. Now, if we alter neuroplasticity, we're going to favor dependence, anxiety, depression for those patients with dual pathology. Then there's the kappa system, which is so important for dual pathology. We will see that later on when we talk about pharmacological treatment, but this regulates stress, and this is crucial for abstinence periods. Now, if we stimulate the kappa receptor too much, we're going to increase dysphoria and the risk of relapsing. So that's why AOT for kappa receptors are so important for patients with dual pathology. And then there's another receptor, which is a delta receptor. It's an emotional modulator, and it leads to a lower risk of dependence than that of other opioids. And it has an effect in impulsivity and in other features. Now, what are the options in terms of pharmacological treatment? Well, we have AOT, like naltrexone and naloxone, and we also have opioid agonists that activate receptors in a controlled manner for maintenance. We have alpha-2 adrenergic agonists that are used at the beginning when we start treatment, when we started 30 years ago with clonidine and guanfacine, or also we have symptomatic treatment. Now, the guidelines recommend us methadone and buprenorphine as first-line treatments, and oral morphine, long-acting oral morphine, but this is a drug that we do not have in Spain. And the guidelines tell us that pharmacological treatment is fundamental, and it is complementary to add psychosocial intervention. Now, handling abstinence syndrome, this is something that leads to poor results. These are mental health, chronic diseases because of deficiency of endogenous opioids. So most of our patients will be under this opioid replacement programs. So it may lead to harm reduction, but with this opioid substitution, the patients will increase their quality of life. And what kind of total agonist of mu receptors do we have? We have methadone in Spain, and as partial agonist receptors, we have buprenorphine with a very interesting antagonism for kappa receptors. What has been the evolution of treatment? Where are we? Well, since 1960, well, fortunately enough, there's the beginning of replacement programs with methadone, a total agonist, daily administration, oral tablets. In 1990, we had buprenorphine coming up as a partial agonist, daily administration, sublingual tablets, and then we add in the year 2000 naloxone to avoid any parenteral wrong use or misuse. And since 2018, there is long-acting buprenorphine with subcutaneous injections. Monthly or weekly. Now, what is the difference between total and partial agonists? Now, as we see in the picture, total agonists are very potent. They lead to analgesia, euphoria, respiratory depression. They have this intrinsic activity of those natural neurotransmitters. However, partial agonists, they're able to bind to receptors and produce only some effects, like analgesia, and not euphoria or respiratory depression. So it is interesting because of well, depression problems with our patients. There are certain studies that tell us that using total or partial agonist will reduce the risk up to 8 times during treatment. So it reduces mortality 8 times, and mortality increases significantly whenever the treatment is interrupted or if there is any relapse. And the strict criteria to access treatment lead to a limitation in a populational impact. So what we have seen in terms of opioid agonist to reduce intravenous consumption, we've seen, and it also reduces the sharing syringes, sharing needles. We see as well that after 8 months of study, we see that there's a significant reduction in the intravenous injections. So they are very important to reduce the risks in this population. Now, there's also this study that tells us that the use of agonists will reduce transmittable diseases, infectious diseases like HIV or hepatitis. When patients inject opioids, the risk of infection increases. Also, well, shared needles or unprotected sex, and currently the prevalence is 10% in new diagnosis of HIV in the US, and the importance of integrated treatments is very high. We need centers that will screen specifically for HIV and hepatitis on those users of opioids and patients of dual pathology. Now, in terms of safety, respiratory safety, studies say that buprenorphine is much safer, and because there's a kind of ceiling effect. I mean, regardless the dose that you give to the patient, even if the patient may take more tablets than necessary, this respiratory depression will be maintained. If there's alcohol intake and benzodiazepine intake, this respiratory depression may increase. So it's very important to monitor the patient. And now regarding the prolonged QT risk, it's much more frequent with methadone. Whenever we initiate a treatment with methadone, we need to carry out an ECG, especially for patients that will move towards high doses of methadone. And we have to monitor the hypopotasemia, and we have to use drugs to prolong QT. And this studies tells us about the use of buprenorphine versus methadone. And both methadone and buprenorphine have a very similar retention, 43–47% retention rates. It is true that studies tell us about a higher retention for long-acting buprenorphine, but there are less studies of this substance than of the previous substances. And actually the determining factors to use one or another drug is the preference of the patient or the access to unsupervised dosing, the individual cost, because in Spain, sublingual buprenorphine, well, patients have to pay at least a part of the treatment. Now, what would be the profile of candidates for buprenorphine? Well, basically, women mainly, because, as we were saying, the prevalence of dual pathology is higher in women than in men. So these women suffer much more regulation mood disorders, or they suffer much more depression and anxiety. So we've seen that buprenorphine is better for patients who are studying or working. It is less sedative than methadone. Also, patients who are stigmatized by the fact of going to a center to collect the medication. Young patients, it is much better accepted, buprenorphine, or again, patients who are active because buprenorphine has a less sedative effect. Now, for homeless patients and for former inmates, because of the lack of adherence to treatment and because of the lack of a stable doses of buprenorphine throughout the month, then we need a long-acting buprenorphine for those. Now, what is the prevalence and the efficacy of this drug? Well, in 6 weeks, they they reduce the consumption from 97 to 12% after 16 weeks of taking Buvidal. And also, well, patients comparing now sublingual versus injectable buprenorphine. Well, this study tells us that sublingual is much better for people who suffer from diagnosed mental diseases or untreated hepatitis C. Now, we see that we have therapeutic alternatives that may work much better for certain patients than for others. And now we will see that from the point of view of dual pathology. According to the latest data on the National Plan for Drugs in Spain, well, they tell us that 40,000 patients are under treatment with methadone and only 6,000 get buprenorphine and naloxone. And we don't even have the data for long-acting buprenorphine, but I'm sure that is less than 1,000 patients under this kind of treatment. And now to finish, we're going to talk about the differences between methadone and buprenorphine from the point of view of dual pathology. And let's see what scientific evidence tells us. Now, there's this study by Maremani from 2011 that told us that methadone seems much more effective for patients with psychotic symptoms, whereas buprenorphine would be more effective for patients with an aggressive behavior, violence, suicidal tendencies, well, patients who have emotional regulation problems. So what is the clinical decision from the point of view of dual pathology to provide methadone or buprenorphine? Well, first of all, we have to make a general assessment. We have to check whether there are other mental disorders, the risk of suicide, the adherence or non-adherence to treatment, and the risk as well. Now, buprenorphine, as a kappa agonist, well, is very good for patients with depression, and methadone is a pure mu receptor agonist, so it would be good for patients who need a potent analgesia or potent sedation or patients with psychosis. So first of all, we need to have this psychiatric screening before initiating the treatment, and we need to have multidisciplinary coordination between all the addiction centers. And literature tells us that buprenorphine is much more effective for depressive symptoms, and the kappa antagonist and the serotonergic modulation offer a better antidepressant profile, and it is much better as well for patients who have mood disorders that are concomitant to the OUD. And now, regarding stress, there's the kappa receptor, which is key for dysphoria. And if we stimulate kappa receptor, there's going to be more stress and dysphoria and more compulsive consumption. So with agonists like buprenorphine, it will reduce craving and negative motivation. So buprenorphine will be very effective there. And now in terms of pain, chronic pain, buprenorphine reduces chronic pain, and it's very effective. It has a better safety profile. We need to bear in mind that normally these patients take other opioids as well, so this would be safer medication. And actually, Dr. Roncero, in the next presentation, will tell us much more about this. And methadone tells us, well, according to the studies, methadone reduces the psychotic symptoms and it reduces as well the doses for antipsychotic medication. And now to finish, well, the conclusions. We do have therapeutic alternatives from a pharmacological point of view that are effective to deal with this disorder, with OUD, and we need to use precision medicine. We need to individualize patients. We need to see what kind of dual pathology accompanies the OUD, and evidence and studies tell us which is the optimal treatment from the perspective of dual pathology. Thank you very much.
Muchas gracias, Pablo. Y ya vamos terminando con
Thank you very much, Pablo. We finish with the last reporter of this symposium, Carlos Roncero, who everyone knows. He has worked his whole life in addictions and dual pathology. He is the president of the Spanish Association of Dual Pathology and professor at the University Miguel de Cervantes, even if his primary links are with the University of Salamanca. He will tell us about the importance of dual pathology in the opioid use disorders and suicide.
Bonjour. Muchas gracias.
Good morning, everyone. Thank you very much. Thanks to the organizers, Jean-Pierre, Arkaitz, his team, who takes us everywhere. And thanks for letting me speak in Spanish. It will be more fluent, and I hope that the interpreters can be adapted to my path if I speak too fast. Well, we are in a marvelous spot with a subtropical climate. It's a pity we are not a surfer and we can't use the beach, but we were invited to tell you about relevant or important matters about addictions, dual pathology. And I will tell you about suicide in people with disorders due to opium use. Relevance of suicide in our society. And afterwards we will tell you about the people with troubles due to use of opioid use disorders out there. So dual pathology. And I can underline other troubles, other disorders. Suicide, well, it appears in very different contexts, from medical diseases, from situations like we've seen dramatically the COVID pandemic, mental disorders, the most frequent one, depressive disorders, and it affects grown-up women, men. These data are from Spain, but in France the data might be similar, more men than women, more the elder than, it affects more the elder than standard or mid-age. In Spain, unfortunately, we have 4,000 suicides committed per year. We don't know how many correspond to people with mental disorders or disorders OUD. But suicide affects sensitive populations such as children and kids. With COVID, the self-lesions have triggered the suicide gestures and suicide trials, which consumed, and they had a peak which fortunately is going down. We could see the increase, the peak of self-lesions of essais de suicide trials, well, and in teenagers. But I am telling you of suicides, but the suicide behavior includes several things. Until the idea of suicide, this tentative de suicide, as well as consumed suicide. There have been discrepancies as for how to categorize, classify all this. I will tell you about the idea of suicide as well as attempted suicide attempt. We made this reflection with other European colleagues in patients with troubles due to use of opioids. Those treated are treated with opium agonist drugs, and these drugs, well, we cannot forget that they are depressors of the central nervous system. They can use for treatment or for phenomena of abuse and other dependencies, other substances, other drugs which are depressive of the central nervous system, alcohol, benzodiazepines, and etc. This tells us that we have a pharmacological predisposition to generate death when we used in a combined and decontrolled way. Suicide in people taking drugs, in drug users. Well, according to our surveys, this has been linked to impulsivity, histories of abuse, other disorders, other mental disorders. You have here the references, and within this context, there is the screen to raise awareness and to train the professionals, the physicians, to adjust the treatments as for the prevention of the suicide risk and the early detection of ideas, so they do not commit suicide. It is important what we are doing here as for health education, so we all go back home aware that we need to evaluate, we need to assess on a permanent basis through time the suicide risks. There is also a subject which is particularly relevant. We were discussing a bit before how many overdoses of opioids are suicide attempts and how many deaths are consumed suicides. We know it partially, though very little, when a patient with overdose, when he tells you whether he wanted to commit suicide or that he didn't care, she didn't care about dying. So using these opioids, but well, the dealer had changed, they didn't know about the purity, or I just changed the doses. Well, what for? Because once the rewarding effects do not increase, even though you would augment the dose. Well, clinically there is this doubt, or at least this issue. This subject of overdose or side effect or possible deaths, we need to study it permanently with any kind of substances. I bring you this recent article, this paper of dextromethorphan. These are not the drugs we are used to think about, but remember that any opiaceous substance must be in the radar of suicide factors of risk. several weeks ago, this paper, this interesting paper, was published by an Australian group, colleagues very well known, where they try to assess the factors associated to these suicide attempts, as well as the self-provoked harms. They were studying multiple factors in a cohort very large. During 11 years, more than 40,000 people were tested, and they got a conclusion that there are factors which are more involved, amongst others being in hospital, having other mental disorders. They mentioned the borderline people, psychosis, having depression or anxiety. So, as you can see, we get back to the dual disorders in patients, older patients, also for legal matters such as having been put in jail recently. Well, they would talk about the average of the percentage of people committing these suicide attempts, achieved or not. Fortunately, it is not very important in the cohorts, but these are avoidable deaths. In this second part, I want to share some data compiled together with my colleagues of Barcelona. When I was introduced, it is true that I am professor at the University of Salamanca, though I work at the University Miguel de Cervantes of Valladolid, at least this academic course. These data come from the University of Barcelona. We studied a large number of patients, more than 3,000 who came to medical care for the treatment of drug dependencies. They were more than 18 years old, so data from more than a decade. We included those with OUDs, and they followed a protocol I told you about several years ago, with 3-4 months of assessment with trained psychologists. There was a psychopathological, clinical, and socio-environmental assessment. Unfortunately, many patients could not end all the assessment. The patients, well, almost 4,000, were excluded of the test, of the trial, because they didn't present this OUD, and amongst those who were included, half didn't complete the assessment. There were some with language barriers or legal problems. And finally, we surveyed 329 patients. A first reflection, this is the work of a decade. It is costly to study these patients in a comprehensive way. And data, well, probably they are a bit biased of survival. As for those who come to these assessments, this doesn't mean that the other 1,600 didn't take treatment, didn't follow the treatments, but they didn't participate in an appropriate way in the assessment sessions. This paper I presented to you was accepted. We have the draft document since March or April. Unfortunately, has not been published yet. We trust that in the edition of November, December, it will be published, but we are not 100% sure. We do not know how they will upload to PubMed. We know that the North American have an issue, a complicated issue with the administration, and one collateral effect is that the maintenance of PADME is a bit slower, or it is even stopped. I hope that by the end of the year you will be able to read this paper. What did we find with this sample of almost 400 patients? Well, suicide ideas were more detected or screened in more than half. 1 out of 2 had suicide ideas, suicide intentions. There was even a pilot study of us, but this marks that we need to pay attention. 1 of 2 patients have suicide ideas, and 1 out of 3, 35%, had suicide attempts. So this is a number of patients which is extremely high. We need to pay attention, not only physicians and psychologists, also nurse teams who are in permanent contact with patients when they supply methadone or buprenorphine, well, any drug, because they can do an important work in the detection and in the screening and prevention of these disorders of these suicides. Well, there are other factors. I will not get into too many details about the data, the ideas of the suicide attempts, but I need to tell you that the presence of other mental disorders, psychosis, for example, is linked, is binded to ideas or attempts. We were studying the sample from Urubasi, and when we value the scales and subscales of this Urubasi, in this population there were subscales which were linked to employment, alcohol use, not employment, use of alcohol, with statistic corrections with Bonferroni, etc. What was associated was the subscale of psychological alterations. Indeed, it is a way to measure the presence of other troubles or other traits if we look at it another way, but it is the field of dual diagnosis. When we accomplished the multiple regression, the associated factors about ideas and suicide attempts, it was having other addictions, the more, the higher is the risk, having moments or episodes of abuse, and the number of other mental disorders. What we are highlighting, as we say in the works we are doing, we put first the relevance that a patient who uses substances with a dependency, if there are dual disorders, be careful, because the complication levels will be higher. There is data that we don't study, but that I don't want to forget in my presentation, so you can incorporate it. And the factors for suicide attempts is having
Recording in
La
progress.
première chose qu'il faut faire dans ces cas-là, à mon avis, c'est traiter les soignants. Parce que c'est souvent eux qui posent le plus de problèmes et qui empêchent les patients d'accéder aux soins. Voilà, c'était quelques remarques.
Care. So these are my comments.
Y a-t-il une question, du coup?
Any further questions? So hello, I'm going to speak French. Florence Forsa from the University Paris-Cité. My question is for Carlos Roncero. And actually, you presented results that talk about suicidal ideas or suicidal attempts for patients who have opioid use disorder. And actually, well, we have the idea clinically that these are medications that protect against depressive episodes or suicidal attempts. Do you have any clinical advice for this specific risk for patients who are going to use these opioids versus other substances? Well, normally, yeah, it is understood that opioid treatment would protect from some depressive disorders, and actually there's this data that you presented that was linking this with suicidal ideas. So what would be the differential factor of the use of other substances and the relationship with suicide? Well, regarding the relationship between these treatments and those patients who have depression, well, sometimes certain agonist medications may have a more positive effect in the improvement or the stabilization of mood. I'm talking here about buprenorphine versus methadone, for example. There are other opiates which are less used because, well, so like morphine, for example, in certain countries. And here we have an intermediate perspective on that. When we talk about opioid users, we need to bear in mind that normally these are users of other substances as well. I mean, there are not that many pure opioid users. Normally, we need to check and to balance the use of these opioids and other substances because, for example, there may be stimulants like cocaine may have an antidepressant effect, at least punctually. So, well, what I mean here is that we need to carry out a very thorough assessment when we think about the use, the consumption of that person, and what kind of level of depression the patient may suffer, because we're talking about a dimensional issue and what kind of treatment we can implement. I think that the take-home message really for our centers, for our hospitals, is that we need to carry out a very thorough evaluation. We need to ask patients. And if we know that this patient has got hyperactivity or psychosis or other mental disorders, well, we need to have this warning light on because these are high-risk patients. And yeah, they are under the risk of having suicidal ideas or suicidal attempts. There's this with HDAD, for example, this would be a profile of patient that would be very vulnerable to suicidal ideas and attempts. I don't know if this was answering the question. Any further questions? Jean-Pierre? All right. And Thank you, Ignacio. Thank you for speaking about the importance of smoking, of tobacco, and the lack of importance it is normally given. I mean, very often patients do not have the necessary screening regarding their smoking addiction. Now, I would like to mention that when we tried to open methadone centers in France, in Bayonne, we could eventually open a center for methadone in 1994. It was very complicated. But now, for some years, now in this war against methadone that we were going through, we were supported by Professor O'Brien from Philadelphia. He was a very good friend of us. This is a relationship that we have, and he's been in the Congress here. And when we opened that center for methadone, well, we were very proud to show him the center. And I remember that there was this waiting room with a corridor, and everybody was smoking there at the time. I mean, both patients and caregivers, everybody was smoking. And whenever somebody, you know, he was saying, well, it's fantastic for methadone, our friend from O'Brien said, it's great for methadone, but don't forget about smoking. Because, yeah, it has been shown in literature that you can treat smoking as well. You can treat smoking addiction for these patients too. So now, from all those patients, we had 3 deaths due to lung cancer and COPD as well. They died from COPD and other respiratory pathologies. So it is true that these patients, well, they are addicted to many things, but they died because of their smoking addiction. Another question?
No.
No further questions? All right.
Bueno, pues si no hay más
All right. Well, if there are no further comments or questions, we're going to finish the session here. Thank you very much for your participation, for being here. Thank you to this magnificent panel. And well, we know that this is complicated because now Nestor SZERMAN and Carlos have to take a plane. I don't know if this will be possible. Maybe you will have to sail back to your home. And well, and now we will resume at 11:15 for the next round on dual pathology and neurodevelopmental disorders.
Hacer una minuta de video con cada uno. Oui, je vais m'attendre ici, on va le faire ici, c'est vite fait. Una entrevista